Yeah, to put the questions small करना पड़ेगा मुझे बस.
It's on only. On only.
Good evening, everyone. A warm welcome to ISA National Online
ऐसे
Teaching
press
Class.
करना पड़ेगा.
कुछ नहीं करना.
These classes are held every Monday at 6:30 p.m. I am Dr. Lily Samcharian, working in MS Ramaya Medical College, Bangalore, as Senior Resident in Anesthesia and Critical Care Department, and I will be one of the screen coordinator for today. In today's session, we will discuss a case of 35-year-old primary gravida with preeclampsia posted for emergency LSCS. So pregnancy-induced hypertension is associated with multiple pathophysiological changes, and anesthesia in these patients involves multiple challenges. All these will be discussed in today's platform. Before we commence with the academic session, let us invoke the divine blessings of Lord Saraswati with Saraswati Vandana. I may now request Honorary Secretary of ISA National, Dr. Sukhminder Bajwa sir, to address the audience.
Thank you, Dr. Lily. Today, we are going to have a very, very important class. I think every one of us, right from the first year of post-graduation till the last day of our practice, we see these cases, the preeclampsia in a pregnant patient. And invariably, I think in a month, you see at least 2 to 3 minimum if you are having a heavy load. So it's not a uncommon, it's a very common entity which you encounter every day. And for you, for anesthesiologists, the challenges lie when the patient present for the cesarean section. Maybe they have kept it for the normal vaginal delivery, but sometimes a condition comes or preeclampsia, there is a notion that it can go to eclampsia or it can have a fetal distress. So many indications are there. And sometimes it's a elective cesarean also. So anesthetic management is entirely a very, very difficult scenario. If you encounter a difficult scenario in this situation, it becomes very challenging. And how you really coordinate with your obstetrician, that's very, very important, because the drugs being used in the management of preeclampsia are definitely going to have a good interaction with the anesthetic drugs also. Your technique is also to some extent modifiable and have to be, changed to the circumstances, to the drugs already given, whether you're going to give a GA or going to give the spinal or going to give any regional. So many things are there. I think this requires a lot of introspection, discussion, and what better than a PG class, especially for the third year PGs who are appearing for the final examination. So let us discuss today with a very good team from the Pacific Medical College, Udaipur, and they are well prepared, I know that, and they are all very enthusiastic. With the PGs, I can see the smile on their faces. They are very, confident, and I think they will be doing a justice to this class. And we are all here to listen to what this team today present to us. So back to you, Lily. You carry on from here.
Thank you, sir. Now I invite my co-screen coordinator, Dr. Upasana, to introduce our faculty moderators and also to outline the session format and rules. Over to you, Upasana.
Thank you, Dr. Lily. Good evening to everyone.
Myself, Dr. Upasana Asuja. I'm working as senior resident in Rohilkhand Medical College, Bareilly. It is my pleasure to introduce faculty moderators for today's session. We have eminent faculty with us today. Firstly, I would like to introduce Dr. Prakash Chandra Aditya sir. He is working as senior professor and head of department at Pacific Medical College and Hospital, Udaipur. He has teaching experience of 8 years and specialty of interest is regional anesthesia, obstetric anesthesia, and he has almost 10 publications. Second, we have with us Dr. Sameer Goyal sir. He is professor at Pacific Medical College and Hospital, Udaipur, with 10 years of teaching experience. His specialty of interest is cardiac anesthesia, and he has over 10 publications. Now, I would like to introduce Dr. Shilpa Sharda ma'am. She is associate professor at Pacific Medical College and Hospital, Udaipur. Ma'am has teaching experience of 6 years and specialty of interest is critical care. Ma'am has over 6 publications. Lastly, I would like to introduce Dr. Krishna Gopal Jangir sir. Sir is working as associate professor at Pacific Medical College and Hospital, Udaipur. Sir has teaching experience of 7 years and specialty of interest is regional anesthesia and critical care. Sir has publications around 7. Welcome, sir, and welcome, ma'am. Now, I would like to share the rules for today's session. Firstly, you all will be kept muted throughout the session. And please keep your videos off during the session. Secondly, if you have any queries in between the session, you can type them in chat box and all your queries will be answered at end of the session. Now, I request today's faculty to please take over the session and introduce your residents for today's class. Over to you, ma'am.
Dr. Shilpa ma'am, you can do the honors of introducing your PG students.
Good evening, everyone, senior faculty members, colleagues, and friends. I would like to invite our second year PGs, Dr. Josiah and Dr. Angu, who will be presenting our class today. Over to you, Dr. Josiah.
So today, the case discussion is about management of a 35-year-old primary gravida at 36 weeks amenorrhea with pre-eclampsia posted for emergency LSES. So our patient is a 35-year-old housewife from Bhilwara, Rajasthan. She is a primary gravida, 36 weeks of gestation, came with chief complaints of headache since 1 day, nausea and vomiting of 1 episode, reduced fetal movements since 1 day, and swelling in both the legs. So she has no complaints of blurring of vision, no history of dyspnea, no abdominal pain, no right upper quadrant pain or epigastric pain. She mentions no history of bleeding PV or leaking PV, no history of seizures was also mentioned. So she was found to have a BP of 170 over 108 mmHg and 166 over 102 mmHg on 2 separate readings on admission. And she was planned for an emergency LSCS in view of reduced fetal movements. So her past medical history, she has no history of hypertension, diabetes mellitus, thyroid disease, jaundice, seizures, or bronchial asthma, no history of any allergy, no history of any surgeries in the past, no familial history of hypertension also. So her obstetric history, she was married at the age of 20. She conceived spontaneously. Her menstrual history is normal, and her LMP was 9th March 2024. Her estimated due date of delivery was 14th December 2024. Her personal history, she is a graduate, and she mentions no history of any kinds of addiction. She has a non-vegetarian diet. Her bowel and bladder habits are normal. On general examination, our patient was conscious, oriented to time, place, and person, and is cooperative. Her weight was 69 kgs. Her height is 160 centimeter. BMI is 26.9. She has no pallor, no icterus, no cyanosis or clubbing. Bilateral pedal edema was noted. Her vital signs on examination, heart rate was 87 beats per minute. Her blood pressure was 154/98 and 150/90, 15 minutes apart. 15 minutes apart. She was started on injection magnesium sulfate, and injection labetalol also was given in the emergency department. Her room air saturation was 98%, and her respiratory rate was 21 per minute, and she was afebrile. On her airway examination, her mouth opening was adequate. There was 3 finger beds. Her Mallampati grade was 2. She had no loose tooth or no buck teeth was present. Neck extension was normal with normal neck movements. Pyromental distance was 7 centimeter. Her spine was unable to palpate the spinous process because of edema. On systemic examination, her cardiovascular system, S1, S2 was heard. Apex beat was heard at the 5th left intercostal space, lateral to the mid-clavicular line. No murmur was present. Her respiratory system, trachea was central. Chest movements were symmetrical, and bilateral air entry equal and clear in all the 3 lung zones. On CNS examination, she was conscious, oriented to time, place, and person. CNS examination was also normal. Per abdomen, her gravid uterus was present, consistent with gestational age. Fetal heart sounds were heard. On ordering labs, her complete blood count, HB was 10.6 gram per deciliter. Platelet counts was 1.4 lakh per cubic millimeter. WBC was 9,000 per cubic millimeter. Her renal function test was ordered, and serum creatinine was 0.7 mg per dl. Proteinuria of +2 dipstick was present. LFT, AST was 40 international units per liter, and ALT was 45 international units per liter. Bilirubin was 0.7 mg per dl. On coagulation profile, her PT-INR was 15 seconds and 1.2. APTT was 30 seconds. ECG was normal sinus rhythm. Blood group and RH typing was done. It was O positive. She had a fasting status of 8 hours, and aspiration prophylaxis was done, and her high-risk consent was taken. So in summary, we have a 35-year-old primary gravida at 36 weeks of gestation with preeclampsia with severe features, ASA grade 3, with single live intrauterine pregnancy. So due to uncontrolled hypertension and decreased fetal movements, she was planned for an emergency LSCS.
Okay. So, Dr. Josiah, what can you tell? Can you go to the first slide, please?
Go to the next slide.
First slide, yeah. No, after this one. Yes. So from the history, what can you tell me? She is presenting for the first time with this blood pressure and symptoms?
Yes. So she had a normal antenatal visits, and it was not detected she was having any hypertension. It was just since one day she's been having such symptoms, and then she came to the emergency department, and we figured out that on examination that she has got a hypertension of 166 and 177/108. Previously, it was not noted.
So what does this tell you about the type of or indication of the disease?
So this is it's like a late onset of preeclampsia, because she is having symptoms like headache, nausea, vomiting, and swelling in both the legs. So it's a late onset of preeclampsia, not diagnosed previously.
Yeah. So based on that, what kinds of classifications are there?
So preeclampsia is classified as hypertension that occurs post 20 weeks of gestation with presence of proteinuria or not.
Can I come?
Yes, sir.
Shilpa ma'am, can I come?
Yes, please.
Joshi, madam is asking the classification of hypertension in pregnancy,
Okay.
not preeclampsia classification. There is nothing like preeclampsia classification. Classification of hypertension in pregnancy.
Okay, classification of hypertension in pregnancy is systolic blood pressure more than 140 or diastolic.
No. Classification of hypertension. Classify hypertension. Types of hypertension
Type of hypertension.
in pregnancy. There is classical chronic hypertension, gestational
Okay.
hypertension.
Gestational hypertension is there. Preeclampsia is there. Preeclampsia with severe features is there. Chronic hypertension is there. Preeclampsia with superimposed. Chronic hypertension with superimposed preeclampsia.
Now, with your history that you have
Yes.
taken,
Yes,
what
sir.
is your provisional diagnosis and what are the features in favor of this provisional diagnosis?
So, since this patient is present with blood pressure of more than 160 over 90, and that is a classification for severe preeclampsia. So that was my initial diagnosis for this patient. And she has features other than hypertension, that is headache, which is one of the other criteria for diagnosing severe preeclampsia.
Okay, what is the definition of preeclampsia?
So preeclampsia is hypertension that is detected post 20 weeks gestation. That is more than 140 over 90, associated with or without proteinuria or with systemic manifestations.
Basically, preeclampsia is the severe form of gestational hypertension. What you
Yes, sir.
have defined is gestational hypertension.
Yes.
And gestational hypertension associated with one or more end organ system involvement is
Yes, sir.
preeclampsia.
Yes, sir.
It may be associated with proteinuria or not.
Or systemic or not, yeah.
So what are these systemic organ system involvement, end organ involvement? What are the features?
So in the end organ involvement includes one of the first thing that is the renal, which includes proteinuria, is seen in such patients. That is normal criteria, but systemic manifestations include your pulmonary edema, one of the things. In the CNS systems, you have your headache, blurring of vision, right upper quadrant pain, epigastric pain, increased liver enzymes, or then you have also your creatinine levels are increased twice of baseline or more than 1.1 mg per dl. These are the systemic manifestations of preeclampsia.
What is the basic pathophysiology that occurs and leads to all these end organ damage?
So in a normal pregnancy, what happens is there is the cytotrophoblasts of the placenta invade the spiral arteries of the uterine spiral arteries and cause remodeling. This remodeling causes the vessels to become low resistance vessels, allowing more adequate blood flow to the placenta, causing adequate growth to the growing fetus. But in the case of preeclampsia, there is abnormal or incomplete cytotrophoblastic invasion, which does not cause remodeling of our vessels, of the uterine spiral artery vessels, thereby causing less blood flow to the placenta, hypoperfusion, hypoxia, which in turn causes fetal growth restriction. And this hypoxia and hypoperfusion causes release of anti-angiogenic factors that causes widespread generalized maternal endothelial dysfunction because of release of cytokines. And thereby we have all these systemic manifestations we have seen in preeclampsia.
Do you anticipate a difficult airway also? I mean, as opposed to a normal gestational patient?
Yes, ma'am. Pregnancy is generally considered to be having a difficult airway because of generalized edema, upper airway edema is seen in normal pregnant patients. But in our case, it is further aggravated because the patient already has hypoalbuminemia because of proteinuria. And there is maternal endothelial dysfunction is there, which causes leaky capillaries. So fluid from the intravascular space goes into the extravascular space, making the upper airway very friable and difficult for intubation and laryngoscopy.
Okay.
How will you diagnose this patient is in respiratory distress, pulmonary edema, going in pulmonary edema?
So if the patient shows signs of dyspnea, difficulty breathing, and that's one of the main things that we will look for. And this, saturations are falling. So is one of
Anything,
the signs.
anything on auscultation? Anything on auscultation?
Krebs would be heard.
Auscultation of,
Auscultation
yes,
would be Krebs would
Krebs,
be heard.
Krebs, and visible sign raised JVP.
Yes. Okay, sir.
And a theoretical aspect S3 heart sound, S3 galopaging.
Okay, sir.
Okay.
Can we go to the next slide? So why did you ask this blurring of vision or history of dyspnea? What are you trying to elicit from this history?
Again, as I said, that preeclampsia has systemic manifestations, and one of the systemic manifestations is seen also in the CNS, as there is widespread maternal endothelial dysfunction. There is leaky capillaries. So fluid from the intravascular space goes into the extravascular space, causing swelling of the brain, and this can cause other symptoms like headache, blurring of vision, and all the CNS manifestations that we see.
Any
that is why
particular reason for the blurring of vision? Something to do with the retinal?
Yes, optic nerve sheath diameter could be, there's a swelling of the optic nerve, could cause a blurring of vision also. Increased ICP could also show.
Yeah. And what would be the reason for your abdominal pain in this patient?
So the other manifestation of the preeclampsia is the hepatic area. The liver could be also affected, and that can cause, there's again hepatic microcirculatory dysfunction occurs, and there is increased liver enzymes like transaminases, which could lead to bleeding further if it's aggravated, and cause right upper quadrant pain or epigastric pain, like referred pain, and that is also a very great prognosis from our side.
Yeah, so basically your leaky capillaries and hemolysis can cause a subcapsular bleeding maybe in the liver, and that may cause pain in the abdomen, which you are trying to elicit right upper quadrant pain or epigastric pain.
Yes, ma'am.
Okay. So she has no history of seizures, but she has headache, continuous headache, which is not subsiding. So,
yes, ma'am.
So you are going to grade this severity grade the disease as how mild, moderate, severe, how?
So the classification for it's classified as severe preeclampsia without severe features and preeclampsia with severe features is having either headache or right upper quadrant pain or pulmonary edema or creatinine levels are increased. But in our case, the patient has headache, which is a severe manifestation, as well as the BP was more than 160 over 90, which is again puts us into the category of preeclampsia with severe features.
Okay, so that is why you're trying to elicit this history, right? Correct?
Yes, ma'am. Yes, ma'am.
Okay. Can we move on to the next slide? Okay. No, the previous one. Any predisposing factors from the past medical history that you would say that would support her disease?
So she is an elder primary gravida. That is one of the predisposing factors, risk factors for preeclampsia. She's 35 years of age. That is elderly primary. A nulliparous woman is also one of the reasons for risk factor for getting preeclampsia. So she has no familial history of hypertension, but these two things, like the elderly primary gravida, the nulliparity, are the two risk factors which support our diagnosis.
Okay.
What are the other risk factors which predispose to this preeclampsia?
So the other risk factors are, sir, chronic hypertension if the patient already has hypertension before pregnancy, or if Apla syndrome, obesity, BMI more than 30, gestational diabetes mellitus are all risk factors for having preeclampsia.
That it
Family
is.
history.
Okay. Can we move on to this investigation part? You have done CBC. What is the significance? She is having a hemoglobin of 10.6. Okay.
Yes, sir.
10.6. And suddenly you find on the second reading the hemoglobin is increased to 12 or 13 without transfusion. What might be the cause?
Hemodilution.
No. This is hemoconcentration because these are volume constricted patients.
So yes. So because they are hemoconcentrated patients, so it can cause increase in hemoglobin levels in such patients because there is leaky capillaries, and so the fluid can go out of the intravascular space to the extravascular space, causing the hemoglobin to increase in
And
such
the
patients.
second scenario is suddenly patient develops pallor. Hemoglobin drops down to 4, 5, or 6. What might be the cause?
So the most probable cause would be abruptio placentae, which would be one of the main reasons that we would suspect in such patients with sudden loss of hemoglobin.
Good. And second is HELLP syndrome.
HELLP syndrome. Yes, sir.
Good. And what about serum creatinine levels? This
So,
patient is
serum-
having normal creatinine levels. And what about in eclampsia, preeclampsia?
So in our patient, she is on the normal side, 0.7 mg per dl. But other patients, what happens is that the serum creatinine levels, if it increases more than 1.1 mg per dl, it is a systemic manifestation showing that the kidneys are affected and it can compromise. And
And 2 times the baseline. You can say in that terms also. Previously the baseline is normal and it is increased to twice the baseline
Twice.
number.
yes,
That kidneys are involved. Okay.
yes, sir.
And what about liver enzymes, SGOT, PT?
So even as I said, hepatic dysfunction can also occur, and the liver transaminase levels can increase twice from baseline, which is also a marker for hepatic involvement in preeclamptic patients, along with right upper quadrant pain. So in our case, the patient's levels are within the normal ranges. So so we can rule out hepatic involvement as of now.
Is there any role of bedside echo in this patient? In such type of patients?
Okay, so in history, I ruled out any episodes of dyspnea in such patients. If a patient comes up with complaints of dyspnea, or and a patient also has edema in our case, but she has no complaints of dyspnea or orthopnea, so I would not go for an echo. Otherwise, I would go for an echo, bedside echo.
To assess left ventricular function and cardiomyopathy, okay, because of this catecholamine cells. And what
Yes,
are
sir.
the role of ultrasound? What is the role of ultrasound in these patients?
So ultrasound can help us a lot because it can help us to rule out, if the intracranial pressure can also be increased. If we can do a POCUS for optic nerve sheath diameter, for an ultrasound for the lungs to show if any pulmonary edema is there, and also echo can be done also. So we can rule out all these things if we have an ultrasound.
You can assess the volume status by ultrasound by
Okay.
seeing IVC, inferior vena
IVC,
cava
yes.
collapsibility. If it is more
Yes.
than 50%, you can see the volume status.
Yes, sir. Okay.
Would you like to do electrolytes for this patient? You have not mentioned.
Yes, I would. I'm sorry, ma'am. I forgot to mention that. Electrolytes, yes, to know if the patient's serum sodium and potassium levels are within the normal range or not.
Any
What is
significant?
the significance? Any significance of sodium?
Yes, because of cerebral because the patient can cerebral edema, because swelling in the brain can cause CNS manifestation. To rule out anything of hyponatremia.
Hyponatremia patient can also throw seizures.
Yes, sir.
So we have to rule out whether it is because of preeclampsia or it is because of hyponatremia.
Yes, sir.
Okay.
Any significance of potassium level?
So potassium and magnesium has a relation. I'm not able to recollect it right now.
Maybe we can go later once we're in the when we discuss the magnesium part. Okay, maybe
ma'am.
next slide. So why have you done the coagulation profile?
So we do coagulation profile because generally there is thrombocytopenia in patients, gestational thrombocytopenia. And if there is liver hepatic involvement, and it can derange the coagulation profile and can cause bleeding in such patients. So to rule out any bleeding, we do the coagulation profile in such patients.
Okay. So now this patient is in labor room, right? Or has she been shifted to the operation theater? Already
No,
posted
presently,
to LSCs.
yes, posted for LS, but is in the labor room at present.
Okay. So what are you going to do? They said they're posting it and they have to take up immediately. So what preparation will you do?
So the first thing that I'll be doing is to secure 2 large bore IV cannulas
with the patient's consent.
With the patient's consent, and then give an aspiration prophylaxis in such patients, because generally all pregnant patients are considered full stomach. So that is one thing. Second thing, and also take a high risk consent for such patients before shifting to the operation theater.
So has your patient received any treatment in the labor room for
Yes.
this? Yeah.
Yes, ma'am. As I said, that she was found to have hypertension, like more than 160 over 100 and 170 over 106. So she was started on magnesium sulfate, and she was given IV labetalol,
20
mg
over 2 to 5 minutes.
What is the dose of magnesium sulfate, or what regime? Any particular regime or anything?
Yes, ma'am. We follow the Zuspan regime, which is injection magnesium sulfate 4 to 6 grams over 10 to 15 minutes, followed by infusion of magnesium sulfate 1 to 2 grams per hour.
For up to?
So we continue, we start the magnesium sulfate when the patient comes, intraoperatively and postoperatively up to 24 hours, or since the last episode of seizure, whichever is first.
Whichever is later.
Whichever is later, sorry.
And
So
how will you give labetalol?
Injection it's given IV labetalol 20 mg over 2 to 5 minutes. And then we wait and watch for 10 to 15 minutes and see if the blood pressure reduces. And yes.
are we supposed to monitor anything during administering these drugs?
Yes, especially when you give infusion of magnesium sulfate, we should monitor the urine output, the deep tender reflexes, the respiration of the patient, because it can lead to toxicity and can cause grave outcomes.
What are the levels that coincide with this?
So the normal therapeutic range for prevention of seizures is 5 to 9 MEQ per liter. And more than that, the first sign that we would see that is loss of deep tender reflex, which can occur around 10 to 12 range. And more than 15, we can see respiratory depression. And about 25 MEQ per liter, we can see cardiac manifestations.
Okay. What do you see in cardiac manifestations?
So the things that we see is in ECG, we can see widened QRS.
Mm-hmm.
Then we can also see
asystole too. By chance, if there is widened QRS, complex asystole can also occur.
Okay.
And also there's decrease in heart rate.
You should begin with, it is calcium antagonist. Initially, it causes bradycardia, hypotension, but loss, decrease in BP. And later on, with increasing levels, it may cause asystole. Okay, and what is the mechanism of action of magnesium in reducing seizures?
So as you said mentioned right now, it is a calcium channel antagonist. it inhibits your NMDA receptors, which provides an anti-epileptic effect, and also causes CNS depression and small vessel vasodilation. So basically, acting on the NMDA receptors helps in preventing the
It
seizures in such
increases
patients.
the threshold. It increases
Seizure-
the threshold.
Yes, sir. Yes, sir.
Okay. And if you have given labetalol 20 milligram IV, even then
Yes,
BP is not controlled, what will you do?
So again, if I give 20 milligram IV, I would wait for 10 to 15 minutes. And then if still the BP is on the higher side, I would give a 40 mg of labetalol again. And then again, wait for 10 to 15 minutes. And then if the still it's not reduced, I can go up to 80 mg labetalol and a maximum dose of 300 mg per day.
Can be given.
Good.
Okay. Any other
if
drug?
if BP is still not under control, what will you do? Any another
Oral
drug?
nifedipine 20 minutes
Yes.
apart can be given, and apart from that, injection hydra.
So you can
Yes.
give per oral nifedipine can be given 10 mg.
Hydra,
IV hydrolysine also can be
can
given.
also
Yes. Good. Okay.
Hydrolysine dose?
Hydrolysine is a 5 mg given, and we have to
10.
wait for over 10 to 15 minutes wait. And you can give another dose of 5 mg, and maximum dose is up to 20 mg in a day.
Okay.
What
So
is your target for blood pressure control? What is your target?
Our target is our systolic blood pressure around 140 to 150, and diastolic blood pressure around 90 to 100. We should not bring the blood pressure down rapidly to 120 over 80. That's not our target. It's 140 to 150, the systolic, and diastolic 90 to 100.
Okay. Now, how will you proceed in OT?
So, so my anesthetic management for this patient, I would go for subarachnoid block since there are no contraindications. And after taking high risk consent, I will shift the patient to the OT, sir, and I will go for a subarachnoid block.
Why subarachnoid block? What is the advantage? What are the advantages of subarachnoid block over general anesthesia?
In subarachnoid block is the most safest in such patients because it avoids airway manipulation. As always, pregnant patients have difficult airway. Also, the hypotensive response to intubation and laryngoscopy is avoided in such patients because they're already on the hypertensive side. And it was also observed that pre-eclamptic patients have less severe, less frequent hypotensive episodes post-spinal. So they have a better hemodynamic control and better perioperative pain control.
And
So
you are also avoiding polypharmacy
yes,
of
sir.
general anesthesia.
Yes, sir.
And what might be the advantage of general anesthesia over this regional anesthesia?
So general anesthesia is only done when there's a contraindication to subarachnoid block, like if the patient is throwing seizures or there's hemodynamic instability,
That is asking what is the advantage? Why when you prefer GA?
There's a better.
So when the patient is having active seizures, so we can't go for spinal anesthesia. So at that time, we have to take the patient in GA. So when there is uncontrolled seizures, so at that time we have to take the patient. So that is one advantage of GA when compared to subarachnoid block.
Basically, when you started your case in subarachnoid block, all of a sudden patient have thrown seizures. Then you have to go for airway protection and under GA. That will be an emergency situations that will cause, although the patient is also a difficult intubation.
Yes, sir.
And that will cause more sympathetic stimulations rather than elective general anesthesia. And vitals are more under control in general anesthesia.
Okay, sir.
That is the only advantage of general anesthesia. Okay.
Okay, sir.
Now,
okay, sir.
In spinal anesthesia, will you give that we call during every spinal anesthesia, we co-load the patient, we preload the patient in such type of patients?
So in pre-eclamptic patients, we would, sorry, sir.
Will you do this preloading in these eclampsia, pre-eclampsia patients?
No, sir. We would avoid preloading. We would be using a judicious, we will be giving fluids very judiciously. we will be co-loading instead of preloading such patients.
So basically, restrictive fluid management
Strategy.
Yeah.
Yes, ma'am.
Okay. You are managing this patient, and before shifting this patient, suddenly the patient has cardiac arrest. What will you do?
So
Patient
the
is
first
still in
thing,
labor room.
okay.
Tell me why sudden cardiac arrest can happen in these patients? What could be the causes?
One of the reasons, already the patient is having hypertension, so it can lead to MI.
Okay.
Stroke could also be a reason.
Magnesium toxicity should be.
We are talking
Magnesium
about
toxicity.
cardiac arrest.
Is there a
Magnesium
thromboembolic
toxicity is also-
phenomena increased? May I join your questionnaire?
Yes, sir. Yes, sir.
Yes, sir, please.
Is thromboembolic phenomena increased in these patients?
Sir, I'm not able
Sorry,
to.
sir, can't hear you.
Thrombosis phenomena can be increased in these patients.
Thrombolytic phenomenon. Thrombolytic phenomenon.
Sir, I'm not really sure, sir. I'm not able to know that.
So the most common cause in cardiac arrest for this patient is because of what? Something you are giving. You yourself said.
Magnesium toxicity.
Magnesium toxicity could be a
Yes.
reason.
Yeah, that's
Exactly. So that is what sir is saying. So if you have
Okay, sir.
a patient who has arrested when you are on Magself, what are you going to do?
So immediately stop the magnesium
Exactly.
infusion.
First
And we
thing
have
is
to-
stop that.
Yes.
And we have to secure the airway and start CPR.
And
when the
before
patient
that,
is-
you'll do
You
this
should
on your own.
No, we will
Call
always
for
call
help.
for help.
We'll just call for help.
Mhm.
And then we will start CPR with and ask someone to do a manual left uterine displacement.
Very good.
And-
Very good. Why is it so? Why you displace left
So
manually?
because there is IVC compression that is occurring to allow blood
Yes.
flow to the heart. So we do a manual left uterine displacement.
Otherwise,
and we
you will
start
be
the CPR.
pumping empty heart. Otherwise, you will be pumping an empty heart.
Yes.
Venous return is important.
Venous.
Yes, sir.
And cardiac arrest causes, no doubt, magnesium is important. Others are because of high catecholamines. These patients might be in cardiomyopathy.
Okay, sir.
Cardiomyopathy, left ventricular dysfunction,
That's
and
true.
arrhythmias. They may show arrhythmias. So they may go in cardiac arrest. Okay. You have started CPR. You are giving CPR. So what about the child, fetus inside? What will you do?
So we as we said that we start CPR, we call for help, and for 4 minutes we do CPR and we see if the patient's return of spontaneous circulation. If there is no return of spontaneous circulation within 4 minutes, we do a perimortem cesarean delivery and to save the fetus, because it can cause hypoxia and neurological damage to the baby.
Why you have chosen 4-minute time?
Because so more than 4 minutes, the fetus can have CNS neurological deficits.
Irreversible brain injury. Irreversible brain injury because of hypoxia.
Yes.
And this CPR and perimortem cesarean, at what place you are doing?
Wherever the
Wherever
place
the
the patient
patient
has the cardiac arrest, irrespective.
The ward, OT,
Good, very
labor
good.
room, marital,
Very
it
good.
should be on spot.
Okay. So now the patient is in OT and you have given everything, and patient is delivered the child. Will you prefer oxytocin or ergometrin? What?
We prefer contraindication is methyl ergometrin because it can cause
Why is it
hypertension.
so?
It can increase the blood pressures.
Yes.
So we can give carbetocin, we can give oxytocin, or we can also give carboprost, but not ergometrin. It's absolute contraindication.
Okay.
If your patient under spinal, sorry, sir.
What is the side effect of carboprost?
The side effect of carboprost is respiratory difficulty. Bronchospasm is there. So it is not given in patients who is known case of asthma.
All these patients are prone to get the pulmonary edema?
Yes, preeclamptic patients are prone for pulmonary edema.
Is it your advisable to give the carboprost directly into muscle or into IV? You will like to give directly into the uterus or into IV?
I would prefer to give it intramuscularly, directly.
Directly. Is there any role of misoprost?
Misoprost.
Are you using
Misoprost?
these drugs in the
No, sir.
cesarean?
No, sir. No, sir.
No misoprost.
We use it, but
But
that's
not
obstetric
in
side.
obstetric. It's not used in obstetric side. Post-operatively, to control the bleeding, we can use misoprost.
Okay, in your patient you've delivered and you notice now sudden hypotension. Patient is under spinal anesthesia, baby is delivered, and you've given your oxytocin. Then patient has some episode of hypotension. What would you do? How would you manage this?
I would give early use of vasopressors in
Mhm.
such patients to
Which
maintain.
one? Which
Preferably the drug of choice is phenylephrine,
Okay, why?
because it is a direct potent it's a sympathomimetic. It causes
Mhm.
vasoconstriction. It is a powerful alpha-1 receptor agonist. So it increases your systolic blood pressure, diastolic blood pressure in such patients. Yes.
Dose
So
is 5 microgram to 10 microgram.
Okay.
1 to 2 microgram.
25.
Yes.
So in spite of maybe 1 or 2 boluses, your blood pressure has not increased. Then what will you do?
If after repeated doses of phenylephrine, if there is no increase in the blood pressure, then I would start the patient on noradrenaline, NORAD support.
Okay, infusion.
Infusion support, yes, ma'am.
Yeah. And what will be the dose of that?
4 mg and 46 ml units, and we can start from according to the BP, and we can start the infusion.
You'll have to read the dose for that. That is not a dose.
Okay, ma'am.
Okay.
Okay, what might be the cause of this hypotension? What might be the cause of this hypotension that is not responding to phenylephrine, and you have to start this noradrenaline infusion?
There could be
Immediate cause.
blood loss.
Blood loss due to
bleeding.
Blood loss is bleeding. Patient uterus might go in atonic.
Yes.
Atonic uterus.
Atonic uterus, yes, sir.
PPH basically, right?
PPH.
Yes.
And you have seen, you have sent this blood for investigation for PT-INR or APTT, and they are saying the blood is not clotting. What might be the diagnosis? There is no clot found. What is a dreaded complication of preeclampsia, eclampsia?
DIC, disseminated intravascular
DIC, yes. Then what will you do?
Vitamin K.
Blood transfusions, massive blood transfusion. You have to go for massive blood transfusion.
Okay, sir.
What is massive blood transfusion? You are replacing almost whole blood in 24 hours.
24 hours, yes.
Massive bleeding is more than 150 ml per minute. Okay. And what might be the side effects of these massive blood transfusion? This massive blood transfusion.
Acute lung injury may happen.
That is TRALI.
Transfusion acute lung injury can happen.
Yes, and what might be the immediate side effects?
Immediate side effects, patient.
Immediate is hypothermia.
Yes, sir, hypothermia.
Acidosis.
Acidosis, ma'am.
So you have to maintain the temperature of the patient. Otherwise, this hypothermia also develops coagulopathy.
Okay, sir.
Okay.
What can you tell us about HELP syndrome?
So it is hemolysis with associated elevated liver enzymes and low platelet count, which is mostly seen in the preeclampsia patients.
It is severe variant form of preeclampsia.
So what do you find? What are the findings in HELP syndrome?
So you have an abnormal peripheral blood smear. On peripheral blood smear, you can see echinocytes or Purr cells or schistocytes. On low platelet count, less than 1 lakh cells per cubic millimeter, or liver enzymes are elevated. Your AST is elevated.
The value of the baseline
is seen in such patients. Also, there's increased levels of LDH also seen in these patients, more than 600 IU per liter.
Okay. Okay, so now, so the patient is delivered, everything's fine. You've managed the hypotension. Dr. Samir, patient is intubated or still under spinal? I've forgotten.
Let it be the situation कि the patient was having the platelet count of around 70,000. What will be the you were doing this case in spinal anesthesia, right, Joe?
Yes, sir.
Let it be the situation the platelet count was 70,000.
Yes,
So
sir.
will you give the axial block or not?
So I would look at the risk versus benefit ratio in such patients. If
What is the cutoff limit for this platelet count?
cutoff limit is 80,000 according to
Now
guidelines,
this patient is
80,000.
having 70,000.
Yeah. So according to the literature guidelines, it says that up to 70,000, if the patient is not obese or if their airway is not compromised, if we suspect difficult airway, we can go for a spinal anesthesia. We look at the risk and benefit ratio and we can go for that depending on the
Now
patient's
the
condition.
platelet count is 50,000.
I would not go for
Spinal
spinal anesthesia. I'll go for a general anesthesia in such patients.
General anesthesia. Okay. Now over to Shilpa, madam. Now the surgery is over. The patient is in GA. How will you proceed?
Okay, so we forgot to mention a few things in general anesthesia before you converted to general anesthesia. Since it was emergent, I think patient had a cardiac arrest. But otherwise, supposing you're opting for general anesthesia because her platelet count is low. So what are the things or what are the precautions you'll do like prior to intubation or prior to induction?
So as difficult airway, we are already anticipating. So my difficult airway cartridge will be ready in such patients. I will also try to call for help from a senior anesthetist in such cases. What is it?
Yes.
Yes,
Proceed.
you're right. You're right.
And then there is also the aspiration risk. So I have to be.
Yes, you covered all that. You mentioned aspiration.
Okay. And
Anything
also the
regarding the during intubation, anything regarding that?
yes, there can be a
You are going for
catecholamine
elective
surge.
intubation.
Yeah.
You are going for elective intubation. What are the precautions you will take?
So again, I will do 100% pre-oxygenation of this patient before intubation. The other thing is that there is increased sympathetic stimulation during intubation and laryngoscopy. So I will make sure that I attenuate it by giving drugs like esmolol or NTG or even fentanyl can be given. Priorly, I let the pediatrician know that I'm going to be giving.
So you're going to give
opioids.
all three, or what is your choice?
I would go for esmolol just 30 seconds prior to intubation.
Reason?
Because it is short acting and onset is quick, 30 seconds to 1 minute. I can see the effects seen. So yeah, that's why I would prefer esmolol.
Yeah, because you've given her labetalol prior, right? So
Yes.
why not labetalol? Why esmolol?
So labetalol, the onset time is among approximately 4 to 5 minutes. So if I have to give labetalol, I have to give it before induction. That is 5 minutes before induction.
So it takes time for it to act. So you are preferring esmolol. And why prefer esmolol over fentanyl?
So fentanyl is generally not advised to give because it can cross the placenta and can cause respiratory depression, neonatal respiratory depression in the babies. So if I'm opting for giving fentanyl, I have to let the pediatrician or the neonatologist know that I'm giving an opioid and they should be ready with the resuscitation equipment in case if the baby post-delivery has any respiratory depression.
Yeah. So, and what other?
Anyway, you would like to increase the ICP at the during time of the induction? Is there any significant effect in the ICP?
So I would
ICP
avoid.
Is important in these patients or not?
Yes. So they will be. So I would preferably avoid succinylcholine because it can increase ICP. And for intubation, for rapid sequence induction and intubation, I would use rocuronium, provided I have Sugammadex with me.
Is there any significant role of fentanyl increase in ICP?
Yes, the fentanyl increases ICP levels.
And why you want to use the fentanyl?
It is one of the It is one of
The
the
patient,
drugs
the
that.
patient is on the magnesium sulfate. You already enumerated this thing.
Yes,
And
sir.
is it not a sufficient drug?
Yes, sir.
It is
It
only
is sufficient.
it is controlled in all seizures, or it is analgesic also.
It has analgesic effects also, sir.
Do you need fentanyl at the time of induction?
No, it's not.
Can you not go for the inhalation at that time?
Yes, we can go for inhalational, but it is one of the ways we can attenuate the sympathetic response. But we would definitely want to give opioids post delivery of the baby only.
Any role on circulation, fentanyl, respiratory depression, cerebral
Yes.
edema? So would you like to avoid analgesics, opiate?
I'm sorry, sir. I'm not able to get the question, sir.
There is a great controversy regarding giving the fentanyl to these patients.
Yes, sir.
It is better to avoid as far as possible.
Yes, sir.
Only indication is the last moment, then when magnesium sulfate is not working properly. You can use the inhalations. ICP is very, very important in these patients because cerebral edema.
Yes,
We
sir.
don't want to increase even the minimum amount of the ICP increase. That's why it is advisable to give in very expert hands to avoid to reduce the cerebral edema as well as fetal distress.
Okay,
If diagnosis is not up to mark, then he will just kill the child.
Okay.
Okay, sir.
Very cautiously.
Regarding induction agent, which one would you prefer?
I would go for a propofol of 1 to 2 mg per kg.
Okay.
For inducing the patient.
Any precautions while giving propofol?
Yes, I would be doing a rapid sequence induction and intubation with modified with Selix maneuver.
Yeah. Okay. And your muscle
relaxant
of choice?
Sir?
Muscle relaxant of choice.
I would go for an atracurium, low dose, because we are giving magnesium sulfate intraoperatively also, which can prolong the neuromuscular blockage. So shorter duration, like atracurium is preferred for such patient, a lesser dose.
Can you monitor any way? How can you monitor whether your dose is adequate or inadequate? Your muscle relaxation.
But trainer force stimulation is one of the ways we can check the adequate depth of the neuromuscular blockage.
Yeah. Okay. And
once I have told there is a laryngeal edema in these patients. Okay.
Yes, sir.
Generally, we intubate so many times by the short-acting muscle relaxant. Why you want to avoid this short-acting muscle relaxant in these patients? You are avoiding the scoling. Why you want to avoid?
So scoline has a side effect of increasing your intracranial pressure. So
yes.
If I have the option of rocuronium in case if I should have sugammadex in hand with me, so then I would go for rocuronium is the drug of choice in such patients.
It is not having an increase in the ICP.
Yes,
Good.
yes, sir.
Yeah.
Okay, and how would you maintain this patient? Maintenance of anesthesia?
Good.
I would maintain the patient on oxygen and sevoflurane, and maintenance of anesthesia will be on sevoflurane and oxygen.
Any advantage of sevoflurane over the others?
Sevoflurane acts on the uterine muscles, so it helps in even more relaxation of the uterus. Sevoflurane.
Okay, and what would be the concentration of the MAC that you would recommend?
1 to 2% on the lower side for pregnant patients. MAC of 1 would be sufficient.
Okay.
Because they're most sensitive.
Okay. Dr. Kishan Gopal?
Yes, ma'am.
Why don't you ask a few questions now?
Yes, ma'am. So, Joe, tell me now the surgery is over. Okay. Everything goes well. You have extubated the patient or under spinal, the surgery is over. Now, where do you want to shift this patient? And what are the criteria you want to look for? Before
So this patient was on spinal anesthesia or was on GA, sir?
Any.
So again, as we are giving magnesium sulfate and we require monitoring for such patients, I would shift the patient to ICU for up till magnesium sulfate infusion is going on, because it can cause side effects which can be unmonitored in the wards. So I would go for ICU admission for such patients.
Only magnesium infusion or any other?
No, the
other?
patient, okay.
So
the patient,
if the patient is taken on any other infusion supports, so the patient is on multimodal therapy, so the patient should be taken in ICU for further observation, along with routine investigation, which should be sent every 4 to 6 hours.
What will you give for pain management for this patient? Patient has delivered, so
I would go for paracetamol and paracetamol as pain management, or post-operatively opioids can also be given, as well as a tab block can also be given for such patients.
Would you like to continue MedSurf?
Yes, I would continue MaxSelf post-operatively 24 hours, or
You must continue. Yes.
Sir?
Yes, go on. It is
So
one
I
of the
would
indication.
yes, I would continue magnesium sulfate post-operatively also 24 hours, or whenever the last seizure occurred, depending on whichever is later.
yeah.
So this is a very important point. When you are shifting and continuing the magnesium sulfate, you must continue it post-operatively also.
Yes, sir.
You should not stop it.
Yes, sir.
Now you tell me, what is the greatest complication at the time of the eclampsia and pre-eclampsia? There are two stages of the patient. Okay. What are the greatest complications the pre-eclampsia patient we have taken in the OT? What complication you can face most probably? And a patient who is eclamptic, what complications you can face mostly? Can you differentiate?
So
A patient, I have taken the patient of pre-eclampsia symptoms. What can be the cause of the mortality, maximum cause of the mortality?
So one of the causes is hemorrhage.
Yes.
Abruptio placentae, stroke could occur. IC bleed could occur in such
Hemolysis in the central nervous system.
Pre-eclamptic patients are more prone to the stroke incidences.
Yes, sir.
And
yes,
eclamptic patients, if I have taken the patient who is already eclampsia diagnosed and I have taken patient for LSCS, what complications I can face mostly? Stroke or any else?
It could cause also abruptio placentae in such patients. There's risk. No.
That is pulmonary edema.
Okay, sir.
A patient who is known as eclampsia and we have taken, the chances of pulmonary edema are very high in these patients.
Okay, sir.
Okay.
So I would like to ask you, Dr. Josiah, how is the patient safe immediately after surgery once the baby is out, or how long is she supposed to be monitored or whatever? You said MaxSelf, you're giving infusion up to 24 hours, right? So
Yes.
why are we doing that?
Because we give post-operatively magnesium sulfate also because the patient can still throw seizures, even though at present after the surgery, within the surgery, during the surgery time, the patient was absolutely fine. Post-operatively, the patient can still throw seizures and there can be complications that could be occurring. So we need to monitor the patient.
So the patient doesn't become normal immediately, right? Is that what you're
Yes.
saying?
Yes,
Okay.
yes.
So then would you be comfortable in giving paracetamol because your liver enzymes are raised? So again, coming back to my previous question, what are your choice of drugs for a post-operative analgesia? Can you give paracetamol in this patient?
In our patient, since there was no hepatic dysfunction, I could go for paracetamol.
But better to avoid. And what about NSAIDs? Would you give NSAIDs to this patient?
We would not give NSAIDs because there is endothelial dysfunction which could affect.
You have proteinuria already, right? Although your creatinine is normal, but you have proteinuria, so that means there is some insult to the kidney. So
yes, sir.
you would avoid. So what is how would you give post-op analgesia? You mentioned earlier.
I would give a tab block.
Yes, that is one of
transverse block.
Yes.
Or wound infiltration, local anesthetic wound
Correct.
infiltration also I would be going for that.
Correct. And IV, what IV drug choices?
Mm,
You can give opioids in these patients.
opioid, yes.
Yeah, because
Post,
baby is
post,
out now, right?
yes. Post
But
operative, we can give the opiates. That is drug of choice after post operative. है ना? It's
Okay,
better
okay.
to avoid during the anesthesia, but after post
something
operative,
is
we
wrong with the.
can give them opiates.
Okay,
That
sir.
will be better.
Okay.
You can give fentanyl during the operation also, but the expert hands are needed
Yeah.
Yes,
because
sir.
it is only side effects of that patients. You have to give very cautiously fentanyl. As far as general persons are concerned, better to avoid. Give post opiate after post of LSCS.
Okay.
Okay, sir.
Dr. KJ, can we ask some MCQs now?
I think it would be better if Angu will have, because they can share the screen. I don't have
Yes,
it
sir.
on the screen.
Okay.
Sir, one sec.
Yes.
So why don't you share the screen?
Just a moment, please.
Yeah. Okay, go ahead, Dr. Kishan Gopal.
Hello, Madhuri ma'am, can I
Yes, please,
can I wait for
please
the
go ahead. Yes,
yeah,
yes.
yeah. Okay, so this is time for little MCQs. So first MCQ is, what is the main diagnostic criteria for PIH? A, proteinuria, if blood pressure more than 140 by 90 millimeters of mercury after 20 weeks of gestation. C, edema of the face and hands, or blood pressure more than 130 by 85 in the first trimester. Okay, everybody is writing. Most of the answers are coming right. Okay, so B is the right answer. So it is blood pressure more than 140 by 90 millimeters of mercury after 20 weeks of gestation. It's for any kind of gestational hypertension, or we can say it's any kind of hypertensive disorder of pregnancy. Blood pressure more than 140 by 90 after 20 weeks of gestation. Angu, next. Which investigation is most critical to monitor fetal well-being in a mother with PIH? So, A is amniocentesis, non-stress test, chest X-ray, liver function test. So everybody is writing B, 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 B. Okay, okay. Most of you are correct. So it is non-stress test. Right, thank you. Next, Angu, next. Which of the following complication is associated with the PIH? So, preterm labor, abruptio, intrauterine growth restriction, or all of the above. So it's quite obvious. Everybody is right. It is the all of the above. So all complication can happen with the PIH. Next. So what is the definitive treatment of for PIH? Antihypertensive therapy, magnesium sulfate, delivery of the baby, or low dose aspirin? C, mostly. So, okay, so delivery of the baby is a definitive treatment, right? Next. A patient at 32 weeks of gestation present with the severe preeclampsia. Which of the following test is most critical to assess the maternal disease severity? Platelet count, non-stress test, Doppler velocimetry of the umbilical artery, or fetal biophysical profile? Okay, okay, okay. Most of them have given the correct answer. C is the correct answer. Doppler velocimetry of the umbilical artery. Next. In the management of eclampsia, the loading dose of magnesium sulfate according to the Pritchard regime is 4 grams IV over 15 minutes, 5 grams IM in each buttock, 4 grams IV over 20 minutes plus 10 gram IM 5 gram in each buttock, or 6 gram IV over 30 minutes plus 5 gram IM in one buttock. Okay, so this is quite common. Okay, C is the correct answer. Okay, next one. A 28-year-old primate with severe PIH at 34 weeks has a blood pressure of 180 by 110 millimeters of mercury and symptoms of headache and blood vision. Which of the following should be initiated first? Which of the following should be initiated first? Magnesium sulfate to prevent seizures, labetalol to lower the blood pressure, emergency cesarean delivery, or fluid resuscitation. Okay, right. So, okay. So most of you are right. So,
Dr.
see,
KG, can we also give the reason behind the answers, please?
okay.
In short, just in short, with after everybody gives the answers, just the correct answer.
Okay. So this is a 28-year-old primate with severe PIH. Okay. 34 weeks at 34 weeks. So with a blood pressure of 180 by 110 millimeters. So it's come with the pregnancy means like preeclampsia with severe features. Already the BP is more than 160 by 110. So it coming into the severe with and organ CNS symptoms like headache and blood vision. So again the severity. So here we want immediate control. We don't want immediate control to the blood pressure. Rather, we first treatment will be we provide magnesium sulfate and then we move on to the emergency cesarean delivery because that is the definitive treatment as we see in the previous MCQs. So a magnesium sulfate to prevent the seizure is the correct answer. Next. The role of low dose aspirin in preventing PIH most effective when initiated. So this we have not discussed in our general discussion, but we'll take on a look just a while. First, I'm completing the question. The role of low dose aspirin in preventing PIH is most effective when initiated before 16 weeks, between 20 to 24 weeks, after 24 weeks, or during the third trimester. So it is related to the pathophysiology of the disease. So it is now recommended in high risk pregnancy. If we start low dose of aspirin, that is 75 milligram of aspirin per day, if it is initiated before 16 week of gestation, the complication or the morbidity mortality of the patient is found to be very low. So that's why it is now recommended in high risk pregnancy. We are starting with the low dose aspirin. So everybody is right. Okay, A is the correct answer before 16 week of the gestation. Next one. In a patient with preeclampsia, the decision to deliver is indicated immediately in all of the following conditions except, okay? The decision to deliver immediately except. So first is eclampsia, persistent severe hypertension despite treatment, HELP syndrome, or proteinuria more than 5 grams in 24 hours. Okay. This is the correct answer. So we see already these first three entities, they belong to the or classification of the pregnancy-induced hypertension or hypertensive disorder of pregnancy. But proteinuria more than 5 gram can occur in different condition or chronic kidney condition. So that we have to look differently. Okay, so the correct answer is D. Next. So this is the final MCQ, I think. During spinal anesthesia in a patient with PIH, the risk of hypertension is reduced. During spinal anesthesia in patient with PIH, the risk of hypertension is reduced due to increased systemic vascular resistance, decreased vascular compliance, hypovolemia, or increased sensitivity to vasopressors. So everybody is writing A. Okay. Nobody is for D. B. Okay, the decreased vascular compliance now. Okay, so I think both the answers are correct in this question. It's little dicey. increased systemic vascular resistance as well as increased sensitivity to the suppressor. So
Yes.
it is easier, we see lower incidence of hypotension in severe preeclampsia as compared to the normal parturient. Okay, thank you. Can we now go on to Shilpa ma'am, please take over. Angu, can you stop sharing?
Yeah, so there's a good presentation, Dr. Josiah and Dr. Angu. Thank you very much. Very short notice by Dr. Sukhwinder Bajwa sir, and we were
But
very,
they have presented,
yeah, they've,
literally well.
they've done a good job in spite of very short notice.
Contribution.
So well
Shilpa
done.
ma'am, Shilpa ma'am,
Yeah.
this one question in the chat box. Is injection prostatin in uterus is more effective than intramuscular injection?
Yes.
Sorry, I didn't get you.
Injection prostatin giving in the uterus is more effective than intramuscular. That's
Yes.
one question.
Yes.
Yes, it is.
Yes.
The logic behind it should be explained also. Why it is more effective in the intrauterine route or intramuscular route. Otherwise, anesthetist's role is diminished. Every time an obstetrician will be injecting the drug and you have no role just to measure the blood pressure of the patient and doing nothing there. Or either if you are going to do an intramuscular injection or even the infusion or something like that, you have a role. But ideally speaking, Lily, if you ask me honestly, the receptor, whenever you give the prostaglandin injections, they have to act on the receptor, the vascular status, whether they are getting absorbed through the venous capillaries in the muscular region or into the uterus. The only thing you can say the faster action from the uterus is it's in the state of a dynamic contraction and retraction. The vascular, the compliance is increased, the absorption mechanisms are increased because of the continuous muscular retraction and, contraction. And the drug can be absorbed very fast from there. The vascular circulatory system is very, very dynamic there in the uterus, so that the drug has to go to the central circulation first to exert its effect through the arterial circulation. The local effect is minimal, but the uterus is if you are going to inject into the buttocks, suppose buttocks or the arms or wherever you want to put the injection, the absorption mechanisms depends upon so many factors, including the depth, the fat tissues, the temperature, and the site of injection. So many things are there. But in uterus, when you are injecting it, it is at least getting the direct absorption into the venous capillaries and when it gets access to that, it goes to the central circulation very fast. And that's the only reason you can explain why it has got a better, faster action in the uterine injection. That's the logic behind it. Any other more question in the chat box? I think you must.
There's one more question. One person has asked maximum dose of IV labetalol in patients taking oral labetalol 100, 200 OD or BD.
Labetalol.
Yeah, IV labetalol maximum dose in patients taking oral labetalol.
I think it's a total dose. Dr. Josiah, what is the total dose you can give labetalol?
So in IV, we start off with 20 mg, which can be gradually increased to 40 and 80, but the maximum dosage is 300 mg in 24 hours.
Yeah. So I think that is a total dose that you can give in one day.
Yeah.
So, what I think here is, as a PG student, whenever you are going to answer, it's always should be based upon per kg basis. Patients, you can't compare a patient of 45 kg of a female parturient with the 105 kg of a male parturient, whether you take out the lean body mass out of the equation or not. So it has to be calculated on the per kg body weight. That would give you an ideal calculation for what dose you can be giving to the patient in such situations. And anyway, 45 kg patient will not be having the symptoms of preeclampsia as a 80 kg patient may be having. That is more important if you go by the observational studies. So I think per kg body weight is a very good answer, even if you repeat in examination. Dosing in the just on the basis of absolute number, sometimes the examiner may not feel comfortable with the answers. So he can come out with these type of excuses to give you a more uncomfortable atmosphere during exams.
Okay, sir.
Yeah. So one more question. Is high normal oxytocin infusion rate is recommended in preeclampsia patients?
A good question, very good question actually. A daily questions based on the daily practice also. How does the oxytocin act and how does it affect on the cardiac tissue? That's a very, very important part. What is the common cardiac manifestation of oxytocin injection, Andrews?
We have tachycardia, which is seen.
And blood pressure? What about the
Blood pressure also increases simultaneously.
So suppose if the patient is having hypotension, shall we give oxytocin to that parturient? Or do we give to some other inotrope to that parturient? Phenylephrine or mephentermine? Which will you prefer?
For hypertension, I would prefer definitely phenylephrine, sir.
See, I'm telling you now, what happens when you are going to appear for a PG examination, you should know the mechanism of action of that particular drug, so oxytocin. So whenever you have got the heart rate effect, it's a chronotropic effect. It's a chronotropic effect, so it is a very high positive chronotropic effect, the oxytocin, which is going to raise the heart rate. The inotropic effect is the contractility of the heart. We don't want, the oxytocin does have inotropic effect where it increases the contractility, but as I think Dr. Samir Goel in the beginning, he mentioned that particular thing about the venous return and the vascular status, the optimization of the vascular status for the blood pressure to be built up. So the heart is not full of blood, so the inotropic effect is not going to last that long, and it is not going to be helpful for building up the pressure. So the chronotropic effect is a dominant effect of the oxytocin whenever it is injected, either intravenously or in the infusion or into the intramuscular, whatever what you choose. So chronotropy is a very I think in such patients where you have a cardiac disease, now this is not a question of from this seminar or webinar. Whenever you say the patient is having some cardiac disease, many patients with the cardiac disease also present with the preeclampsia and all thing, you have to use the oxytocin very judiciously. Rather than resorting to the intravenous route immediately, it's always better to have a infusion here. And in such cases, you don't worry about the uterine retraction or contraction. Don't go by the panicky nature of the obstetrician attending to that patient because your responsibility is more towards saving the patient's life here. Whatever the chronotropy, inotropic, or bathymotropic or dromotropic effect a drug does have, the dromotropic is a conductivity. In that case, what you do, you have to have build up a case where you inject a drug in such a manner that everything is under control. I think in that case, rather than going with oxytocin purely in such cases, cardiac cases, you use misoprostol sublingually. It bypasses the first pass metabolism, and it helps in the contraction and retraction of uterus. Mainly, your atony will be taken care of, and your bleeding part will be taken care of. Uterine contraction, retraction will be there, and there will not be sudden pumping of the blood into the heart, central circulation, which again can be a cause for the little, subclinical congestive cardiac failure in this patient or a pulmonary edema in this patient, especially when you are encountering a cardiac patient in such things. So you have to be very careful in the judicious use of doses. That's why the role of anesthesiologist come. Every section is not same. Every patient is not same. But the only best part is that these patients are very young. They have got a good compensatory mechanisms which they can tolerate. Otherwise, if patient the cardiac disease come, be careful in injecting any drug intravenously. Intravenous is a route is such a route which you may not be able to control after injection. That is one thing.
One last question. In pregnancy-induced hypertension, before C-section, preloading should be done or not, as patient is already hemoconcentrated. I think it is already discussed in the
Yeah,
class.
I think we've already discussed that we should go
definitely.
for restrictive fluid therapy. So,
Yeah, that's all the questions.
Now I think we should open the what you call this room for the others to answer the things. Just let me make everybody unmute. Yeah, fine. So whosoever wants to ask the question, they can raise the hand or they can unmute themselves to ask the question directly to our very young, brilliant minds. Second year, both are second years, huh, Shilpa ma'am?
yes, sir.
So see, the confidence oozing from the second year, that's how our Indian anesthesiologists are shaping up. And I think the credit goes to the teacher, right from the HOD to the teachers, how they are building up this younger generation into this field. You may not be able to see that much of confidence in the second years of other specialities when it comes to the national webinars. You will never see, because I have seen I've encountered 2 3 webinars of the medical societies, the surgical societies, ENT societies. PGs never represent there. They never present a case there, and see how the confidence is building up in our specialty. That is the beauty of this branch. Dr. Mohan Pathak wants to ask the one question. I think he always ready. Sir is a very senior person.
Sir, whether carbetocin can be used in place of oxytocin? Is it better to go for carbetocin? Nowadays
Sir,
it is available freely.
I will answer that part. The carbopros, sir, any carbopros injection is basically the
Carbetocin,
Sir,
carbetocin.
carbetocin is carbetocin is a mixture, is
Same
almost
thing.
having a
Yeah.
hybrid effect of prostaglandins and oxytocin. But sir, the first line of drug is that there is the in vivo hormones also. We should not forget that it's a human body. What we are using, we are giving a ex vivo, the hormones from the outside. But even if you don't give, the body itself has a mechanism that they will produce the hormones after the delivery of the baby and delivery of placenta, that uterine tissue goes into the contraction and retraction, because this hypothalamic pituitary axis, it's such a beautiful axis. It provides a optimal level of hormones. So it's just a support. Just see, if suppose if we are pushing up a weight, we are taking up a weight of 20 kg or 50 kg from the earth to the head level. At some stage, we may get stuck up with some weight that we may not be able to lift it. Somebody just puts a finger to it and help us to take it further. So this is the advantage of giving the exogenous oxytocin in those patients. Carbetocin, sir, or methylargometrin, or misoprostol, or prostaglandin, sir, almost every drug has the same effect. But the most easily available is the oxytocin in the institutions, in the periphery, wherever it is available. Whatever the RCTs, whatever the observational studies have been conducted, they have been conducted on the oxytocin, sir. The dose has already been defined now, 10 to 15 units. International unit is the optimal dose. You can go up to 40, but sir, that is also a ceiling effect. It does have ceiling effect. Nobody has done the molecular studies on the ceiling effect of oxytocin. But sir, if the 15 internal units of oxytocin is not exerting its effect, that means the further injection of oxytocin is not going to help it. You have to switch over to
Yes.
other receptor binding drugs, maybe carbetocin, maybe carbaprost, maybe the methylargometrin, or maybe misoprostol, whatever it is. The routes you have to define, routes you have to choose, and that depends upon the clinical acumen, and that depends upon the choice of the anesthesiologist, the facilities available there, how to handle these patients after that. So I think, sir, we should restrict ourselves for the sake of PG examination to the oxytocin as the first line of drug, because it is the most commonly used worldwide. And the carbetocin is a good drug to have, sir. It should be on the table, not going against it. But sir, at the moment, we should be restricting ourselves to the PG curriculum with oxytocin 10 to 15 international units. Whether you want to give a little diluted way, 3 to 4 units diluted, injecting immediately, and then you go with the infusion part of the rest of the drugs slowly, so that they have a minimal effect on the cardiac tissue. So that's the way, sir, we are going about it.
Yes, sometimes only 5 units are also enough.
Yeah, that's what I'm
5
saying, sir.
units.
Titration of the
Yes,
drug is
yes,
very important. Sir, here comes the
yes, yes,
experience of the anesthesiologist, where, and you
yes,
should
sir.
have a very cordial communication with the obstetrician continuously, every 2 minutes, whether uterus is contracted,
Yes,
retracted, whether I should. But sir, somehow what happens, I've seen in my clinical practice over the last 25 years, the uterus gets into contraction and retraction, but sir, after some time, when the closure is almost near the completion, the uterus relaxes again sometime. So
yes, yes,
infusion is a very, very important part. So once the infusion is there, the maybe the endogenous hormones may not be up to that much level to keep it contracted and retracted state. But when you provide that much, I think after some time the uterine and when the bleeding stops, the trauma stops, the surgical trauma stops, the endogenous hormones take over these procedure and they are capable enough of taking up the uterine relaxation to a good extent by contracting and retracting it, sir. I think you must have also seen in your experience that after 2 to 3 hours, there is no harm in stopping the drugs also, sir.
yes. If you suspect any problem, you can start with carbetocin only, because what happens is once you start oxytocin, then they will ask to give carbetocin and then again methargine also and prostaglandin also. So in cases of problem, you can start with carbetocin only, no, initially.
Sir, I think that's what I
Yeah.
was saying in almost we have started a practitioner's module also. In practice, especially the majority of the sections are done in the practice. I'm little swaying away from the PG classes here. Sir, in the
Yes.
peripheries, you find oxytocin, and nowadays the misoprostol tablets are there.
That response
And
is very nice.
sir, I have already done a research study on this drug almost 15 years back. And
Yes.
that time it was published in one of the highest impact journal of Asia in the Public Health Journal. So 200 microgram of misoprostol sublingually, if
Yes.
you give it,
Yes. Yes.
I think, sir, I have never seen a case of uterine atony in those patients. You may use
Yes.
20 units, internal units of oxytocin, go to 30. But sir, I have never used more than 25 of oxytocin international units in my life. To very precise, I may not have published it, but in a practical way, how we go about it, because there are many editorials, articles on oxytocin use being used to 40, something like that. But sir, I don't believe those things are going to help us. In a PG career, as a PG student, I will just try to give one message. If oxytocin is not functioning at 15 to internal units to 20 internal units, maximum 20, you should resort to some other drugs. That means already the receptors are saturated. You have to go for the other receptors to bind the drugs for the other receptors so that the uterine contraction attraction occurs in a good way. The carbetocin, the misoprostol, the carboprost, methylaglometrin, I am not advocating here because the patient may be cardiac also. But a sublingual misoprostol is the best answer to anyway. You can use it, you can answer it to any of the examiner in the world, whether it's from India or from US. That's the best way to answer. Sublingual
Rectal also.
misoprostol is the best way to go for it.
Yes, per rectal also.
Parectal also, but parectal a little messy way. I think the patient's cooperation is very important. Just tell the patient when you keep the drug, the tablet under the tongue of the patient, please don't chew it, please don't swallow it. Just let it dissolve in its
Yes,
own
yes, yes,
manner.
yes.
I think patients are very cooperative, sir. Majority of them are under the regional spinal anesthesia only. They are very cooperative in that part.
Yes, sir. Thank you, sir.
Welcome, sir. Yeah, Dr. Madhuri, please.
Sir, have you seen the side effects of the Tarifrost?
Carbiprost, mainly it's the flushing has
Bronchospasm.
been
No.
flushing I've seen, the cardiac
Yes.
effects I've seen basically. But
Yes.
I've hardly used carbiprost in my life, sir. Very, very few ranges where obstetricians have compelled me to do, especially in the government college when I was a registrar. At that time, I was forced to do it because there was no drug available. We were at the mercy of the obstetrician, which drugs to be made available at the counter.
Unfortunately, I have seen so many side effects in the my private practice. Because in private practice, they want immediately to contract the uterus. And the patients who came were almost so many times they were the respiratory problems. So without telling,
Bronchospasm.
so they just
Yes,
by
sir.
I been trapped so many times because they had history of asthma, broncho, COPD cases, and then they have some nausea and vomiting. As soon as the patient comes out of the theater, the relative wants that there must be a smile on the face of the patient. And the patient seems to be stress after vomiting and nausea. They think that the anesthesia is not the proper. So sometimes we feel distress when the patient is not smiling outside the OT. So that is the only drawback of the transit post. Otherwise, it is very good.
Yeah,
So many
yes, sir.
times. Oh.
You know, what I have done in
Only
practice, in fact,
once. Only once I have experienced severe bronchospasm with injection prospholic
Yes.
carbopros. Only once.
Yes,
Severe
sir.
bronchospasm. We had to treat it with bronchodilator and all.
sir, but
Severe
whatever
bronchospasm.
prostaglandins we are using for the obstetric practice, they don't do that much of the bronchospasm. But naturally, the route of administration, the absorption mechanisms of the prostaglandin, they lead to nausea, vomiting.
Nausea, vomiting. It's
It's not
supposed to be
just
Which is
not
common.
the obstetric patient, sir. Any patient, for that matter, even for the if you use the prostaglandin, any patient, if any patient, forget about the prostaglandin. If any patient comes with a nausea, vomiting after anesthesia and to the post-operative ward, that sends a
That is,
very because I know the vomiting and nausea is such a bad feeling for the patient itself. Forget about the relatives.
for
Yeah.
ourselves also. When the
So
relatives are standing by of
yeah,
the
for
patient, it is
yeah,
immediately for us
anesthetists
also.
always feel that it is because of
Yes.
my drugs that patient has started nausea, vomiting. So what we can always do, sir, it's always better to spend some time in the operation
Theater.
theater.
Theater. And then shift the patient outside.
Stabilize the patient there. Do
Yes.
whatever mechanism we can use, whether you was go for a 5-HT3 antagonist or you
Yes.
want to go for the gastrokinetics, which are not indicated, especially in the surgeries, in the spine, this one, the sections. Rather than I think 5-HT3 antagonist and domperidone and some steroid part also, we can
Yes. Yes.
always use them
Mhm.
so that by the time patient shifts to the ward, they are in the best of the health. And especially if you're own hospital, if
Yes.
it's
Yes.
your own hospital, you are going to bear the brand of you're not on your relatives
Any
hospital,
hospital.
any
Yes. Yes. Any
hospital.
patient.
So
Any
wherever
patient.
I think we have been advocating the post of rounds also.
Yes.
The
Yes.
post
Yes.
of rounds are very, very important for an anesthesiologist. See, after this case, you went for another case in the practice. At least you make a sure you come back and see that patient again if any problem is there, because the first 6 to 24 hours, they entirely belongs to the anesthesiologist. The drugs are
Yes.
still in the blood, plasma levels are still there. They are going to cause some effects and you are liable for those actions, sir. So I
Yes.
think these are very practical questions for the PGs
Yes.
also,
Yes.
because many of the PGs are doing the research studies. Research studies, how you collect the data, you go to the wards, you collect the data. But after collecting the data, you don't care about the patient. You just want to see what the patient is complaining. But I think whenever you go for the post-op rounds, make it sure that you are the primary physician for that patient. Take it such a way that patient belongs to you, not to the surgeon. And you ask any question to the patient, whether you are feeling any comfort or discomfort. So that will make you a peri-operative physician. It's just not for the nomenclature. It's become a functional in nature also when you take care of these type of things.
Thank you, sir.
Anybody else want to ask something?
In initial days, we used to give general anesthesia only in all PIs. Nowadays, we manage with the spinal and renal anesthesia. Yes. That's
Dr. Madhuri wanted to ask for a long time, sir. Let her.
No.
You had raised the hand, na? That's
Yeah,
why.
I had raised my hands. Yes,
You lowered it.
my question is totally different.
Not a
This,
difficult one, na?
no, not at all.
Not a gold medal question?
No. This is only for the PGs especially. So
Hey,
Dr.
that means
Josaya,
you have to give some award if they answer your question.
I'll give. So Dr. Josaya and all the PGs, just to make you tell you that when you go in the exam, for when you get a case of PIH for a long case, especially it comes as a long case presentation. So when you go there, you will go totally, thinking that you're going to be asked about anesthesia for LSCS. but please be ready to face other questions. Especially the examiner can take you to labor analgesia for PIH, because labor analgesia is very much indicated in a case of PIH. So the
Yes.
examiner can divert you to labor analgesia and ask you all questions on labor analgesia and send you out. Then they can ask you questions about HELP syndrome. That's very common. So your entire viva can go on that. Or they can ask you about intensive care management of a case of PIH. Or they can ask you about postpartum hemorrhage. The whole viva can go on that. For example, I can very easily divert your viva to management of PPH. A case of PIH is very prone to develop PPH, right? So I can ask you everything about prevention of PPH, management of PPH, and so on. So you should prepare in such a way that you can answer questions on all these conditions, including the pathophysiology of PIH, which is very basic for any, because the examiners often get bored of asking the same questions again and again. So if you have got PIH, the next candidate may have got PIH again. So they're not going to ask you the same thing about LACS, right? So just wanted to tell you about that. So you be ready.
So continuing with Dr. Madhuri's question, next question to the PGs is, you have got a patient of PIH in your labor room, going to be shifted to the OT. In the meanwhile, patient has got scissors. Okay. Already the patient is on Maxelf now, whether a 4 gram injected. Okay, the dose. I'm not asking about the dose. Dose you must be knowing. You must have read almost everything for the preparation for this class. So now we have already gone through the Maxelf doses. The scissors are not subsiding. You are already taking for the patient for the section. You are going to take it the GA. Nobody advocates a regional here in this scissors. You have to do for the GA. But scissors are not controlled. So what are you going to inject next time? How you want to control the scissors?
Can we give the bolus dose again? Because already infusion is going on.
Maxelf always, when you give, you have to be very careful. Already, I think it is discussed in the class, what I heard, the toxicity levels of magnesium sulfate. You have to see the 4 to 7. That is a level you have to maintain per deciliter. 4 to 7, it is ideal. And you have to see the reflexes, the neurological reflexes, the knee jerk and all those things. I'm not going to detail of those things. Those are for theoretical purposes. But magnesium going into the extra doses, your muscle relaxants will have an exaggerated effect. You may not be able to take out the patient, the ventilatory part, the post-op ventilation, the post-op obstetric ICU may have to get ready for those things. You can't go with if the 4 gram is not going to subside anything, repeating is going to hamper. I think you may repeat it also.
Yes.
Because when the 4 gram is already done, already entire receptors in the body have been saturated or occupied with the magnesium ions basically. So next dose may take some time to occupy the remaining receptors or whatever the remaining receptors are there. If it's not subsided, what is the next drug you want to have in these cases?
I will go for IV lorazepam 4 mg.
Yes, good.
The patient is going to be, baby is going to be delivered. You are going to taking for cesarean section. You have to see the abacus also.
Yes, sir. Or else I will go for a thiopentone sodium. And I will
do you have your table in the present day in the Pacific? Thiopentone, while you have seen thiopentone.
Yes, sir. It is very much available in Pacific.
Great.
But we are not routinely using it, but it is very much available.
Yeah, that's great. HOD has to answer on this part. I know that it's a responsibility. HOD becomes more important.
In our time, we used to thiopentone drip for these patients eclampsia.
Nowadays, that's why I asked, sir, because now that's 2 decades back we were using it actually.
Yes, sir. Nowadays this phenobarbital is almost absolute, not available easily.
I think
that's why we are switching to the
I think what Bajwa sir meant is
Pardon?
Who's Dr. Lily, you are saying?
No, Dr. Shilpa.
Shilpa ma'am is saying.
Shilpa madam.
Yes,
Your
yes.
I
voice.
think, sir, what you meant is short-acting benzodiazepine.
Yeah,
Probably
basically
bendazole
Yes, yes.
recommended.
versus
See, so
lorazepam.
now what happens is it's not just anesthesiologist's choice. The guidelines have been into place. The
Yeah.
Foxy,
Yes, sir.
Foxy or ASA or ISA, whosoever developing the guidelines, you have to choose a very, very judicious dose. Dr. Shilpa is very much right here. I think I will go with the either propofol or with the thio, whatever is available with me. It's not that if a thio is not, I will make a panic in the OT to arrange thio for that. Dr. Prakash sir is very good. He has already arranged it for you. But for in many OTs, thio is not available nowadays. So in that case, what I will do, I will go for the propofol and a short-acting benzodiazepine so that you induce. And I'm not going to say about the airway management in these patients. The airway management is altogether a different story. If you start that discussion, it will not end by 11 o'clock in the night. So I will not going to start the airway management story here. I'm saying this class 1, MP1, easily intubated patient. So here we give a very short-acting benzodiazepine plus with GABA facilitating and GABA mimetic drugs. So I think we will go for propofol or a thiopentone with a short dose of midazolam. That's going to control the seizures. Seizures are very, very important to get control. You use the more of a magnesium sulfate, and I think you will not be able to reverse the patient. Eclampsia patient, the mortality becomes high, the morbidity becomes high, and you should be caring about the baby as well as the mother in this stage. Both them. You just want to care about one, you may have end up in the harming the both of the species. So good, just propofol thio plus with a short dose of midazolam. Lorazepam, I think it's mentioned in the books very well, but in the practically, if you answer this question to the examiner also, well, whatever we're using nowadays at our table, I think Dr. Prakash sir is more experienced in these things. He has seen almost best of the both the academics and the practice part. I think here, these are the drugs to be used. You make the scissors die down with the GA.
Yes.
Nobody can manage the seizures better than the anesthesiologist in eclampsia, than the anesthesiologist. Pediatrician, where the role finishes, our role starts. A third year MD students is a better management than HOD of an obstetrics in managing the eclamptic seizures with a compromised airway. See, that's my stake on this thing. So here you can always project yourself that we are the best perioperative physician in these circumstances. And you can always enumerate examples where we can be the best perioperative physician. Take pride in being an anesthesiologist. Any other question from somewhere? Dr. Harpal Singh asked he's a very senior person, ex-vice president of Punjab State Branch. Dr. Harpal, you can unmute yourself and you can ask the question directly. You had asked in the chat box.
Sir, pentazocine in vomiting, role of pentazocine.
Fortwin injection, commonly known pentazocine or commonly fortwin in the vomiting. So, sir, what I experienced in my life is fortwin was very good in a shivering, anti-shivering mechanism. So very good in shivering mechanism.
Pethidine. We use pethidine that time.
Pethidine,
Yes,
sir, pethidine, pentazocine, buterphenol, tramadol.
Yes, that was drug of choice at that time.
All are such a good anti-shivering agents,
Yes,
provided that you use them in a sub-analgesic doses.
Even after Halothane chat, after
Which one, sir?
Halothane, shivering was stopped by the pethidine.
Sir, in the role of in vomiting, sir.
Vomiting, sir, pentazocine role, even I also don't know what role it
No, there is no
plays
role of
logically.
pentazocine. No
Someone
role
written, sir, in box.
So, sir, someone has, hello, sir, Lily here. So, nausea, vomiting common after uterotonic. Here, IV pentacosine 30 mg gives instant relief. So, 1%.
No.
I will go with the evidence-based things here in the PG's classes. In practice, we may adopt many practices. We may say this is my practice or doing that practice. But during the PG classes, we have to say those things which are helpful for the PGs and not just the individual reports without evidence, without any controlled trials or without any evidence or without any validations. Those things are very, very important because in the PG classes, the message is very much clear. we should be teaching the PGs those things which are they going to answer in examination. After they pass on an examination, whether they palpate the liver with their foot or with their hand, I'm not caring about that thing. That's their practice. But during the PG examination, let them pass. So we can always restrict our discussion to the things which can be practiced in the post-graduation career, which are very much evident, which are very much established practices. We are using those. Yeah, some things we always practice, but those are established in the journal under the trials, in the clinical trials, RCTs or meta-analysis, which are the gold standard for the literature, which can come in the book anytime. So those we can always say in the PGs. The rest practices are very much there. Dr. Madhuri again wants to ask something.
I'll take the questions.
Just 2 minutes. Just to add something new to this. These nowadays the wave of POCUS is there, like everywhere it's POCUS. So the role of POCUS in preeclampsia, you have told partially, Dr. Josiah. Can you just tell the role of POCUS in the case of preeclampsia?
Dr. Andrew, before you answer Dr. Madhuri's question, I will tell you, you search the Google, put the name of Dr. Madhuri, Dr. Bajwa, and the POCUS and preeclampsia. You will come across a meta-analysis which have been written by us, and you will get all the answers there. And that's why Dr. Madhuri wanted to ask this question here.
Yeah,
So anyway, but it's a very, very good question she asked. You must, Dr. Madhuri, rather than asking them, you explain to them also.
Yeah, I will tell you. So the POCUS nowadays POCUS is there everywhere. So the ultrasound plays a major role in management of cases of PIH. So starting from top, you can start with the optic nerve sheath diameter. You know how to estimate the optic nerve sheath diameter with the ultrasound. So as the diameter will increase when the ICP rises, and the ICP will rise parallel to the PIH. Then comes as you go down, you have the lungs. So in the lungs, what will you see? If you do a lung ultrasound, in a case of PIH, either in the labor room or on the operation table, what will you see?
B lines.
Curly B lines.
Just 1 or 2 things you tell.
Curly B lines.
No. Curly B lines.
No.
No. They are never known as curly B lines. They are known as B pattern. B pattern. Curly B lines are seen in pulmonary edema on chest X-ray. Okay. So you see the B pattern. You can calculate the lung ultrasound score. You can calculate the echo comet score. You can calculate the E dash ratio. And basically the B pattern that indicates that there is extravascular lung water. So you have to be very careful in this case when you give the IV fluids to prevent pulmonary edema. Then coming to the spine, you can use ultrasound for locating the intrathecal space or the epidural space. Okay. Then of course you can do TEE also.
I think
we will not go to that, Dr. Madhuri. I think POCUS is good enough for them.
Yeah. So
they
POCUS,
are second year, third year, they will do TE when they go to the year.
So this is the role of lung. This is the role of ultrasound, POCUS in preeclampsia.
I think IVC also you can see the collapsing.
Yes.
Diameter, collapsing diameter.
Yeah, he told. I think somebody had told that. Yeah. Good.
So I think before moving forward, let me just wait. So it's time to at least honor our class people here. They have done a wonderful work, and the preparation were very good. The second year PGs, I'm always feeling proud when the PGs, second year especially when they present these classes. The confidence in them is because of first of all, right from the HOD sir, Dr. Prakash sir, thank you very much for that team you have created.
Sir, I will give you thanks to you that you invited all my students and my colleagues to participate with you and have an interaction. I give you thanks to all of the team for inviting us for the presentation of my students. Thank you, sir.
Thank you, sir. And this is a small gesture from Dr. President, sir, and myself and Dr. our academic chair. So we are indebted to your team. Thank you very much, sir.
Welcome,
And
sir.
then Dr. Samir, I think the way you started the class today with the questioning of the PGs and the PGs were suddenly dumbfounded, that I liked. It has to be very natural. You just can't get the PGs preparing the answers to every question. The way you ask the question and the way that you make them, somehow paralyzed with the answer, that was a wonderful thing. I like that class. This is a way how our real examination also goes during the final day. Thank you, Dr. Samir, for
Thank you,
being
sir. Thank you, sir.
a good faculty here. And Dr. Shilpa Madam, she is the cornerstone for this class. She was the main coordinator. So thank you, Shilpa Madam. You have been a wonderful, coordinator for this class.
Thank you, sir, for the opportunity. And I would say the environment created on the national online class is all thanks to you. You have made us all so comfortable that our second year PGs were so comfortable in presenting. It wouldn't have been possible without the opportunity given to you by you, sir. Thank you so much.
Thank you, ma'am. It's not me, it's my entire team, my national council and my team. And thank you very much, ma'am. And Dr. Krishan Gopal, you are also very good. I think you are also one of the person who must have been working very hard with the PG students. I know, I can understand how the people really work behind these classes. Thank you, Dr. Krishan Gopal, sir.
Thank you, sir. Before Saturday, sir, we all were like in Jeopardy. How do we do, or how do we do first time the online webinar, particularly at a national level?
Yeah.
But after a session with you, that 30 minutes, it was clear that it's going to be wonderful.
Yeah.
Thanks a lot, sir. Thanks a lot.
Thank you very much for such a wonderful presentation. And I like now to Josiah Peter Andrews, you yourself, and whether you bought the new laptop or you got it from your friend, as well as Angu Mukantan, both of you. You did a wonderful job. Thank you. Thank you, Beta, and I bless you. And you will be doing very good in your examination, both of you, and Dr. Prakash, sir, and Dr. Sameer, Dr. Shilpa, and Dr. Jangir, they will be helping you in your final examination also.
Thank you so much, sir.
Thank you so much. Thank you so much.
Thank you, sir.
A very thanks to Dr. Upasana Suja. She was a beautiful presenter in this class, as well as Lily Samcharian. Very confident. These are our, young stars who are going to be there for our national, faculty. They are the national exposure. The confidence you can see from their faces. They coordinated the classes very beautifully. So thanks to both of them.
Thank
Your
you, sir.
certificates will
Thank
be
you, sir.
posted in the group also. I will be sending, and you will be very happy. You can show it. You can frame it also. And then comes the very much role of our special class coordinators, Dr. Madhuri and Dr. Ridhima. They are always there with me. They are doing a wonderful job in the national level. Maintaining the class and every week is not an easy job. And to such a level where, you have to go through almost every type of topic, covering and the audience question and answers, everything and any doubt. So I'm very thankful to my team. Dr. Madhuri she had a problem, had a family problem she had today. Dr. Ridhima also had a family problem today. She also gone there. So, and they are in the class. So Ridhima is still, she's in the OT, taking care of her family. So that's why she couldn't come. So that's why I'm telling you, these are very, very important moments. And thank you. Such a nice class we had today. And this is a very important topic, and the PG students were well prepared. Thanks to all the 4 teachers, right from Dr. Prakash to Dr. Shilpa, and they did a wonderful job. And this class will be now permanently recorded on the YouTube. Anybody can see, anybody can go through this class. They can see what type of questions can be asked, and nobody can fail after seeing this class during their final examination in the PGs.
Thank you, sir. Thank you.
Thank you so much, sir.
We will invite you as an examiner.
Sir, I always like to.
And you have to ask only this eclampsia.
When I am examiner, sir, no PG fails. In my whenever examination I have taken, no PG fails. Anyway, but the PG should be knowing that because we are taking care of the patient with the best.
Yes, sir.
So
We are playing with the life directly.
Yeah, we are dealing with the type directly. So it's not
Okay.
about the examination only, it's about
Yes,
the
yes.
after the examination.
Yes.
So our next issue is coming. We are working very hard, myself, Dr. Madhuri, and other editors, where we have seen life after PG. So
Yes.
that issue is going to come, the vapor issue, our
Very
newsletter, going to be coming in another 10 days, where you will see the experiences of every person who has passed the PG about how they experience the thing. And patient safety is the cornerstone of every article. Lily is writing up, Upasana, both are writing, I think.
Yes,
Lily
sir.
and Upasana, yeah, both are writing here in that issue. Yeah, so that will also be coming very soon. So thank you. We are very thankful to the Pacific Medical College team of Anesthesia
On
department.
behalf of department, I
Thank you.
invite you. Please come to Udaipur and we will enjoy get together.
Sir, we will
Whenever
be
you
having
get time.
a PG assembly in Udaipur, and that is approved
Yes, sir.
yesterday only. We had a GC
Yes, sir.
meeting yesterday, and
Different,
we have
different
Dr. Lalit Raigar had
Yes.
asked for the PG assembly. I think
Yes, sir.
all the colleges, Gitanjali, Pacific, RNT, every college will be involved in that PG assembly. So we will be coming to Udaipur, sir. Myself, Dr.
Yes,
Madhuri.
yes,
We
sir.
will
Yes,
come
sir.
to Dr. Prakash and Dr.
Yes, sir.
Shilpa,
Most
especially.
Yes, sir.
welcome.
Most welcome.
Most welcome.
Most welcome.
Thank
Yes,
you.
sir.
Okay,
So,
sir.
Thank you, sir.
time to say goodbye, and whenever we leave, always say
Long live
Long
ICP.
live
Long
ICP.
live.
long live
Long
ICP.
live ICP.
Long